because fluid levels are seen in many other regions.
Okay.
Hydrated cyst may be one, but not typical because I can't see the water lily sign in the regions. Maybe necrotizing pneumonia.
Anything else in the lung? In the CT?
I can see that there is opacity in the left lung. That one that you were scrolling over. I just want to exclude that there is any communication with the abdominal cavity. This can be pleural effusion. This is away from the spleen and the kidney. So this one is pleural effusion.
Mm-hmm.
I just want to detect if there is pleural spilited sign or not. In my opinion, it doesn't pick so much with pleural splitted sign. So this is pleural effusion with multiple cavity lesions in the lung. The potential diagnosis may be multifocal pneumonia, multiple lung abscesses, multiple septic emboli with flaring of inflammation in the lung.
What? So this large lesion, is this a empyema or is this a lung abscess?
In my opinion, the angle between the lung is acute. I just want to see the coronal to confirm.
Okay.
My opinion, this keep more with lung abscess.
Okay. And this thing in floating inside it, what is that?
This may be pus component, or maybe rest of necrosis in the parenchyma.
Okay. So you have multiple lung abscesses, bilateral, air fluid level, and thin walled. You didn't mention the wall. And you said there was a pleural effusion, and rightfully so, you said it doesn't look like an empyema. So you consider TB.
All of the lesion is second and irregular.
Okay, so your differential is infection. If this is infection, what else do you want to look for? And you said septic emboli as well. Do you think the patient has a PE? Yes or no?
In the level of the right lower pulmonary artery, I can see filling defect.
Mm-hmm.
I want to trace the rest of the pulmonary vasculature, but I can't detect evidence of septic emboli here in the septic history of embolism in the right lower lung. This right. Okay.
If you had to ask one question about the history of the patient, what would you ask?
Drug abuse.
Yes. So if I say yes, he is a drug abuser, where else do you want to look?
I just want to check the heart to see if there is any endocarditis or septic emboli within the heart.
So would you see endocarditis on a non-gated CT?
I am not accustomed. I am not accustomed. To be honest, I am not accustomed to evaluate endocarditis in the CT. But I can see that there is. I can see that there is irregularities in the wall and the septum of the heart. However, I am not.
So, what's the test of choice to look for endocarditis?
I think equal to see the vegetations.
Yes.
And yes.
So you picked the abnormalities straight away, but I think your mind kept going back to TB for some reason again and again. If you don't see the tree in bud, then you need the scarring. If the only way this can be TB is if this was old TB and the patient had dead space and that got secondary infection.
In the city, I told that I mentioned that the TB is less likely. I think so in the city.
Yeah. So. Well done. So there were extra points in there for PE, and then mentioning that this was thin walled and you were not suspicious for cancer. patient history, and you would recommend further, depending on patient symptoms, echo may be helpful to look for any cardiac abnormality. Let's do one more. Have a go at this one. So the patient is a 78-year-old, increasing cough over the last 2 weeks.
Okay, I am presented
Otherwise
with,
well.
I am presented with plain X-ray of 72 years old male with cough for the last few days. From the first instant, I can detect that there are multiple opacities seen at the level of the right lung lower zone. Again, just can you modify the window a bit to see the pleural distress? I feel the image is a bit harsh. Anyway, in my routine practice, I will do this. I can see that the left lung shows a degree of opacity in the lower zone. On this window, I can't pick the left hemidiaphragm well. So in my routine practice, I will modify to see if there is a lesion in the lower zone silhouetting the diaphragm, left hemidiaphragm. Pleural distress in the left side is obliterated. Here, the constellation of I can't detect any pneumothorax. I can't detect any corresponding cavities in the upper zones. I can see that there is multiple opacities in the lower aspects of the post lungs. This can be pneumonia. This can be multiple small nodules. In my routine practice, I would like to check for FRCR for previous X-ray to see if the patient has progression of such disease or not. And I would like to communicate the finding with the referring physician and recommend CT.
So you're suspicious for pneumonia?
Pneumonia or multiple nodules in the lower lungs.
Okay. So the patient is well, they only have a cough. What kind of pneumonia do they have?
If the patient doesn't have fever, then it doesn't go well with pneumonia, as pneumonia is cause of constitutional symptoms.
What other kind of process could cause this appearance without giving the patient a fever?
Wegener granulomatosis may be one of the causes.
Okay, so Wegener is a term no longer used. It's now called granulomatosis with polyangiitis.
I'm sorry.
Yeah. So, so in Wegener's, you will see. No, in the previous one, you were right to think of Wegener's, not in this one. I know vasculitis can pretty much look like anything, but you want a bit more mixed picture. You want nodules and consolidation and a bit of everything going on if you want to think down the vasculitis line. This is more, like you said, it almost looks like pneumonia on both sides. And I think it is a pneumonia of sorts, but what kind? Pneumonia means airspace filling up with something. So it doesn't automatically mean...
Yes.
Yeah.
Yes. So this cannot be, this can be a type of interstitial pneumonia, not infective pneumonia. So I can see multiple opacities. Just if you don't mind, you can pick on the CT. I just want to zoom it to see. Thank you so much. In this cuts of the CT, I can see that the pattern here, keeping with consolidation surrounded with ground glass opacities. So this keeps with halocyan, but not too peripheral. So this can keep with organizing pneumonia. In my routine practice, I would review the history of the patient to see if the patient is a smoker or not. maybe smoking related disease like ribald or DI, cognitive interstitial pneumonia. However, the pattern of halo sign is more keeping with organizing pneumonia than the other mentioned causes.
Halo sign or reverse halo sign?
In my opinion, I can see consolidation surrounded areas of density surrounded with GGO.
Yeah. So does that automatically mean halo sign? Does halo usually used for more nodal looking areas? Yeah, and the solid bit needs to be a bit more rounded and then surrounding ground glass to call it a halo. This is all, like you said, there's consolidation. I agree. There is ground glass. I agree. After that, you need to think about what that consolidation and ground glass is doing. So this ground glass and consolidation is causing something. It's pulling on the lung. All the bronchi are getting dilated.
Yes,
so all the bronchi are surrounded by linear-looking consolidation, and that's called architectural distortion, and it's called traction, bronchial dilatation. So that process is actually starting to scar, and it's starting to pull the lung around it. Infection doesn't do that. Yeah, they can do that, but it's not that symmetrical and bilateral. Organizing pneumonia is a good thought. You're thinking down the right line, but the pattern doesn't fit organizing pneumonia. You want consolidation. You want, like you said, peripheral consolidation, almost triangular looking areas and all that. This is a pneumonitic process. It is an interstitial process. It is caused by something. You went down the right line. You asked me for the history, and then you said history of smoking. So that smoking wouldn't cause, if smoking caused this, nobody would be a smoker. So sadly, smoking doesn't give us this. Smoking gives us DIP and RBILD, but this is not the appearance for that. Yes. This is so you would, when you say history, you would say you would give me, when it's a interstitial looking process, you want to ask me more exotic questions like, is there history of travel, is there history of pets, is there history of drugs, new drugs? And I would say yes, the patient started in this one and nitrofurantoin 3 weeks ago, and 2 weeks ago their cough started. So this is actually a nitrofurantoin lung, and this is starting to fibrose. It's
drug-induced interstitial pneumonia.
Drug-induced, exactly. That's the diagnosis here. Okay, so I think we're running over. So thank you so much.